Now in orthopedics, we do number of tests. Let us look on those tests one by one. See, for Schauber's test. Schauber's test is used to do for ankylosing spondylitis, and Adams test is done for scoliosis. So how to remember? We have S to A and A to S for these two tests. In Adams, you have to remember that if on bending, forward bending, the scoliosis resolves, then it is postural scoliosis, and if it does not resolve, then it is structural scoliosis. Now we move on to the next test. That is, now we move on to Barlow test and Ortolani. So how to remember Barlow? Barlow, we have bad. Bad means that this is B for Barlow, A for adduction. Adduction means moving towards center of body. That is when thigh is adducted towards the medial side. Then it is bad. Why it is bad? Because the head of femur will come out of the acetabulum. And what is ortolani? In ortolani, you have to do the vice versa. Why is this all this test done for? This is done for the DDM, developmental dysplasia of hip. Now we move on to the next test. That is for thoracic inlet and thoracic outlet syndrome. Now in thoracic outlet obstruction, we have three tests. What are they? Roos, Addison, and Wright. Now in Roos, you have to remember that we can here put the short mnemonic with east. You know that rooster, what it does, it makes sound when the sun rises in the east. That is Murga. So how to remember? See, now this we have east. So what is east? East is elevated arm abduction stress test, in which arm is elevated and abducted, and then there is a stress produced, and then there are various features happening in form of neurogenic and vascular pathology. In Addison, what we do? In Addison, we palpate the radial artery. In Wright we do overhead abduction. For Wright, we can remember by that in Wright we are doing so much right that up till a point we go towards the wrong side. That is for overhead abduction. For example, this person is elevating the hand. It is right until it reaches this point. Now it will change into the opposite thing. It will become bad. Now when it becomes bad, so you can remember that right is, so they are, when they are doing bad, then they are covering it up by sanitizing the name and putting it right. So overhead abduction, right. We move on to, there are various tests for carpal tunnel syndrome like Fallon's test and Tinello's. Then we have Duncan test. Now Duncan test is the most specific for medial nerve compression. Now D. Curvain's tenosynovitis. Now how to remember D. Curvain? What happens is, in this, tendon get inflamed. Which tendon get inflamed? First compartment of the extensor group of muscles. Which are they? See, remember, in this, tendon is getting inflamed, and we can write it as ab pile ex navy p lia. Now you should drink, because her ex has also started drinking. And this D. Curvain tenosynovitis is also known as Finkelstein test. Now D. Curvain, Finkelstein, and very lengthy name, D. Curvain and Finkelstein test. Now we move on to the Cozen test. Now the Cozen test is done for which? Now you must have remembered that Sachin Tendulkar suffered from tennis elbow, and tennis elbow is also compared with golfer's elbow. So how to differentiate? And it is very difficult to remember. See, I will tell you a number of ways to remember. For tennis elbow, what you can remember that lawn tennis, that is lateral epicondyle is inflamed, and golfer will be vice versa. But there is another method to remember it. See, in golf, we are trying to hit the hole which is lying in generally in the direction of the person that is hitting. That is, whenever golfer is hitting, he will not hit the ball from here to somewhere laterally. He will face in the direction of the ball. So the ball will always go medially. But in cricket, what we do? In cricket, what we do is, although we are getting the ball in this direction, but we can hit it laterally. So by this understanding also, you can come to the conclusion that tennis elbow is in lateral epicondyle and golfer's elbow is in medial epicondyle. Now, which is the tendon which is inflamed? See, if you remember that Sachin was not of such a great height. He was not having such high heights in when measured. So, Which muscles would be involved? Extensor carpi radialis brevis. Now, what is the test that is employed to test whether there is tennis elbow or not? So remember that for this we have to also remember that when we say lawn tennis, then we say lawn tennis court. When we say lawn tennis court, then it becomes cosen. Initial two letters are same. So by pressing on the lateral epicondyle, we test for lateral epicondylitis, and that becomes tennis elbow. Now we move on to the McMurray test. Now McMurray test is for the medial meniscus. In this, what happens when we flex? When there is flexion, then there is rotation also happening with it. Now, if we want to know whether in the knee joint whether collaterals are present or they are they have been injured or not, then we will need to understand some tests. What are those tests that are done for the knee ligaments? So there are valgus stress test, varus stress test, and then we have pivot test, and then we have dial test. Now valgus stress test, you have to remember that in knee everything is going to be reverse. That is when it is L, then here would be medial collateral ligament plus medial meniscus. No, you can my bad, it would be only medial collateral ligament. Now for varus stress test, what we can do for lateral collateral ligament. See, this is always an example of reverse mnemonics, that what does not go with whom. So valgus have L, so we are going for medial collateral ligament, whereas varus have LCL. Now we go for the pivot test. Now pivot test is for anterolateral corner of the knee, anterolateral. And the dial test, if you remember, then in the olden age, dial test used to be run in this direction, so it was always opposite, so it would be posterolateral. Now along with this, remember that we do nerve injuries for a median nerve, we do pad test and dab test. Now for pad, for palmar, it does adduction. So what we do, we put card in between the hands, we put a card in between the fingers, and then we try to move it away, so it will be palmar interossei. Now for dab, we have Igawa test. Remember, dab, Igawa, DE. So what we do, we ask the patient to bring the finger close, and then we put hand opposingly, and then we ask them to expand their finger. And if they are not able to expand, then this is known as Igawa test. It is done for dorsal interossei, which does abduction. Now Wartenberg sign, this is an important one because we often miss this. What is Wartenberg sign? Wartenberg refers to radial nerve injury in which there is wrist drop. Radial nerve injury in which there is wrist drop. Now we come on to nerve injury. Now normally we remember the common ones, so I'm not going to repeat here the common ones which we often forget. I'm going to repeat those. Like, remember, for supracondylar fracture, we have to remember AMRU, anterior interosseous nerve, median nerve, radial nerve, ulnar nerve. Now we come on to next. We will see Montagia. Now Montagia, we have posterior interosseous nerve. Now we move on to nerve injuries and their compressions. What were the nerve injuries and the compression associated with it? At what level it is taking, I will try to hear. See, all the factual knowledge you have on different platforms and sites. What I am trying to here do is make some mnemonics so that you can take inspiration from those mnemonics and learn in their own way. Now we come on to the first. For shoulder dislocation, neck of humerus, we have axillary nerve. For quadrangular space, if you remember that axillary nerve goes through it, and also posterior circumflex humeral artery. Now Holstein-Lewis fracture is the radial nerve. Now Montagia. In Montagia, we have to remember that it is pin. So how does a mountain form? Mountain is somewhat like this, but when we compress the mountain sideways, it would become a big pin. So Montagia have posterior interosseous nerve. Now we move on to the wrist dislocation, in which we have median nerve, and then in hip dislocation, again for posterior we will have sciatic nerve, for anterior we will have femoral nerve, for cubital tunnel and Guyon's canal. Just remember that in those two, elbow tunnel and Guyon's canal. We have to remember that here we have ulnar nerve. So how you will remember? By remembering that vowels stick together. See, E and U are sticking together. In Guyon's we have U. So U again for ulnar. And this way you can remember that elbow tunnel and Guyon's canal is associated with ulnar nerve. Also, along with this we also have cubital canal. Now cubital canal is in cubital space, that is the elbow. Now here you have cubital canal, you will have ulnar nerve. Now we move on to the supinator syndrome. Now supinator syndrome we often tend to forget because supinator, supinator lies in the posterior compartment. So here we will have radial nerve. Now chiralgia paresthetica Wartenberg syndrome. Now chiralgia paresthetica Wartenberg syndrome. Just remember it because it is often difficult to remember this. Chiralgia, sensory branch of the radial nerve. Chiralgia, what you are doing, you are cheering. It is a sensation. So just remember that in chiralgia paresthetica, it is the sensory branch of the radial nerve. How you can remember? You remember this also, that you pulling your cheeks. When you are pulling your cheeks, you are pulling your cheeks with the help of palm or hand. So which nerve will be involved in sensory branch of radial nerve? See, it often chiralgia paresthetica is confused with meralgia paresthetica, which is caused by lateral cutaneous nerve of thigh. So therefore, you will have to remember this, that when it comes to chiralgia, it is cheeks, and with cheeks we are stretching it by sensory branch of radial nerve. Now in thoracic outlet, we have to remember that CA-T1 roots are involved in thoracic outlet syndrome. Often questions that are asked in thoracic cases, thoracic outlet, that is CA-T1. And if they ask which is the most common nerve that is involved, it is the ulnar nerve that is involved, because it is the most medial. If you see the anatomy, then it would be when coming out of the brachial back plexus, its fibers are in the most medial most part. So therefore, they will be getting trapped in thoracic outlet. And last but not the least, we have tarsal tunnel. Now tarsal tunnel, that is posterior tibial nerve. Now we move on to the first other different named fractures. One is Galesia and Galesia versus Montegia. Now remember that what we can remember it by the mnemonic Christmas. Now Galesia, inferior part of the radius is getting injured here, and Montegia, superior part of the ulnar nerve is getting damaged here, and superior part of the ulnar bone. Now we come on to the basics of orthopedics. Now we will, there are some trademark questions that are asked, and we should remember beforehand those information. There are some joints that are prone to non-union, malunion, and which, and some are fracture of necessity. Now what happens in non-union? You should remember in non-union we have flips, femur, neck, lateral condyle of humerus, ulna, tibia lower part, and scaphoid, because often we will forget the small bones there that are present. Now we come on to the malunion. For malunion, remember MISC, M for malunion, I for intertrochanteric fracture, S for supracondylar humerus fracture, and C have here two meanings: Colles fracture and clavicular fracture. So this is something that you will have to remember: non-union and malunion. Now there are some fracture of necessity. Now how will you remember fracture of necessity? Fracture of necessity can be remembered by pongulum. First is obvious. P is patella, O is olecranon, N is neck of femur, G for Galesia fracture, L for lateral condyle humerus fracture, A for articular injury, M for Montegia fracture. So for fracture of necessity, you can remember it by the mnemonic pongulum. Now we come on to the next topic, that is deformities. Now for deformities, we will be able to learn it by mnemonic. Remember that gun stock deformity is associated with supracondylar humeral fracture, and it manifests as cubitus varus. Varus means that hand would be cubitus varus, means that the cubitus, that is the elbow part, would be varus towards the medial side. Now after gun stock, we can remember dinner fork deformity is for Colles, because here there is dorsal displacement. When same thing becomes ventral displacement, then it is known as Smith fracture. Now if you remember these two cricketers, then you can easily remember the both Colles fracture and the Smith fracture. See, Colles is equal to Colles. Now name is sounding similar, and Smith will always be same. So both are against each other. So when Colles goes dorsally, forming a dinner fork-like structure, then Smith displaces anteriorly and forms a spade-like structure. Now we move on to the fishtail. Now in fishtail, we have in the lateral condyle of the humerus, there is a small space that are left, and which appears like fishtail. It occurs due to distal humeral fracture. So always remember that fishtail is the fracture occurring in the distal humerus. Now we move on to the different kind of cast that we see. That is hand shaking cast, that is seen in Colles. Now glass holding cast. So it will be like handshake, and it will be, see, Colles would be handshaking, whereas in glass holding cast, we will have seen the scaphoid fracture. We can remember this glass shaking by, now scaphoid fracture can be remembered as Dr. Sky holding glass. By this you can remember that glass holding is associated with scaphoid fracture. And what is doctor doing here? Doctor is basically dorsal deviation, dorsal displacement, and radial deviation. So you can remember it by Dr. Sky holding glass. Now for cylindrical cast, this is involved in patellar fracture, and it has a skyline view. We do tension band wiring. This part can be skipped. Now we come on to chopper. We can remember it by chopper or choppert. Now this fracture is seen with intertarsals. You can remember this by that, like as a chopper. Chopper is used to fly from one place to another place. Likewise, intertarsals are also used. Now we move on to Lis franc. Now in Lis franc you can remember by TMT Saya. That is tarsometatarsal joint, Lis franc. And one more can be used. This is French are subtle people, and in subtle we have a sound of tarsal. So now we come on to the fifth tarsal fracture, C. There's a lot of confusion regarding what is zones fracture, what is pseudozone fracture, what is dancer fracture. So let us eliminate that confusion once and for all. See, whenever the patient were coming to the doctor with a fracture of fifth bone, there were basically 2 to 3 kinds. First, in which the neck of that tarsal gets broken, and that is known as Jones fracture. J, now you can remember that J is for the joining, and where the bone diaphysis and epiphysis join, they join at the metaphysis. And what do they do here? Metaphysis, they join at the fifth tarsal join at the metaphysis. So what happens now? So now when the patient were coming to the doctors, they were seeing two varieties of patient, Jones and non-Jones, or we call it as pseudo-Jones fracture. Now when you see the pseudo-Jones fracture, you come to the understanding that Jones fracture was occurring in the metaphyseal region and was not healing properly. It was not healing, and it was not due to transfer. Pseudo-Jones, it was a very good fracture, and it used to heal quickly and all. So entirely 2 different sets was seen, Jones and pseudo-Jones. When we subdivide pseudo-Jones, when it is the avulsion fracture of the tip of the fifth metatarsal, and that is also known as dancer fracture. Now we come on to the Fadir and Faber concept. Now Fadir and Faber. Now Fadir and Faber, you can remember that Fadir is going far. And where is it happening? It is happening in retic. Now we again go through the what does Fadir and Faber. Now Fadir is when there is posterior displacement. Faber is when there is anterior displacement. Or now when there is posterior dislocation of Fadir, then there is limb shortening. Now limb shortening happening in Fadir, and in Faber limb lengthening. And limb shortening happening, and because this is posterior dislocation, so the most common nerve injured is sciatic nerve, and it is anterior displacement, and therefore femoral nerves gets injured here. Now what are the conditions? We have to remember the condition in which Fadir or Faber is manifested. Now Fadir is manifested in TB of the hip and obvious posterior dislocation. The rest all the conditions are associated with anterior dislocation. What those are all, we can remember that they are synovitis, whatever we pronounce, then septic arthritis, and then we have iliotibial band contraction and anterior dislocation. Iliotibial band contraction and anterior dislocation, that is the obvious part. So remember, see, TB is eating up the bone. You can remember TB eats the bone. Now when TB eats the bone, it is limb shortening, and that will manifest in form of Fadir. Whereas in rest of these here, it will be there would be limb lengthening. Now from here, we discuss the named fractures of the orthopedics and how to remember them. So first is the green stick fracture. Green stick. You can remember that that plants have a green stick, and you are able to easily break the plants that are younger. That is, children have greater green stick fracture in them. Now we come on to the second, that is night stick. Night stick is see, when we are in the dark, so we are trying to save ourselves. So this our hand, the inner side of the hand will project outside. So therefore it would be ulnar. Please note that it is not the radius that is being called night stick, because when you are night stick radius would be on the outer side when we are in anatomical position, but when you are not in anatomical position, then we are this bone radius bone is towards the is coming towards the medial side of the body. So in night time or in night stick fracture, we have ulnar complete cortical fracture. Now we come on to the torus or buccal. Here we see a slight buckling of the bone tissue. Now Bennett. How to remember the Bennett? See, Bennett and Rolando. Now in Bennett we have 2-part fracture. Rolando is associated with 3-part fracture. Now in which digits? Remember that whenever we have to work hard, we have to apply all our force, and therefore that would involve the 5th finger. But when we are not working hard and we are just doing time pass, so then we will see that even the 1st finger will break. So here are, this is, you can relate to this name by the Rolex watches that is worn by the wealthy people, whereas Bennett is also Bennett cars that come and all that you can compare again with the rich class. So what is happening in rich class? Rich class are very fragile, so even their first finger breaks. So therefore in Bennett fracture we have 2-part fracture, in Rolando we have 3-part fracture. Now we come on to the fifth, and that is boxer. As earlier said, that fifth finger is the finger involved in the boxer fracture. Why? Because boxer is applying all its force. So ultimately at the end of the fingers we get a fracture, and that is known as boxer's fracture. Now we come on to the sixth. Now we have bumper fracture and shin-bone fracture. Now bumper fracture we know from our forensics that it is caused by the car bumper striking the legs, causing fracture of lateral tibial condyle. Now what is shin-bone? Now shin-bone, remember this bumper from Kapil Sharma show. Now she has everything glued to her, so she is known as shin-bone. So Segomond fracture is known as the anterior fracture of the retrocapsular ligament associated with anterior cruciate ligament injury. Fine. Now we move on to the pylon fracture. Now pylon is what? When you have a pile of books, a pile of books pressure falls and where at the bottom when it comes in contact with the ground, and that is the ankle joint. Now we come on to the aviator fracture. Aviator fracture occurs in the talus bone, and more specifically neck of talus. Why is it called as the aviator fracture? It is because earlier what happened used to be there that there was no such as mechanism that to make the pilot entry and exit easy. So here is aviator fracture was seen, in which the coming aeroplane person used to jump off the aeroplane, and this often used to fracture of talus. Now we come on to the Potts fracture. Now Potts and cotton fracture are quite easy. Now Potts are exchanged between two people, cottons are exchanged between two people. So what will happen in Potts fracture? We have bimalleolar. In cotton, we have trimalleolar. What we should remember that from Pot we go in the town to buy and sell. So and it is the interaction happening between the two individuals, that is the shopkeeper and the client. Likewise, here also Potts disease occurs. Now Jefferson is Atlas bursting fracture, whereas Hangman is fracture of CT over C3, and Clay Chauvier. Now moving ahead, we can talk about various types of splint. Now we have Kramer's splint. Now when to use cramming? Cramming is done in emergency purposes, like when we have to give exams and all. So it is used for emergency cases. And then we move on to the gallows traction and Bryant traction. See, gallows. In gallows, G'(D) is in air, but whereas in Bryant, touching the base level. So in both these cases, these are done in children for less than 2 years, both gallows and Bryant. Hip spica cast. Hip spica cast is used for heavier kids, that is greater than 2 years. Okay. Now we from here move on to the age-wise management of CTEV. Not much question has been asked in recent parts, but it has been a consistently important topic and can be asked anytime, and it is useful for your prof exam as well if you are a still prof giving student. Now for age-wise management, you should remember that initial treatment for CTEV starts with Ponseti, plaster of Paris, but this would be within 1 year of age. But what if this deformity is corrected? Then we use Dennis Brown splint till 1 year of age, and after 1 year we will use CTEV shoes. This is being used in daytime, and in night time we will use Dennis Brown splint. Now if again, now we move on to when deformity is not corrected or untreated, what we will do? Now in 1 to 3 years we will go by the, see, 1 to 3 years, no, Prime Minister is supreme. So what we will do? PMSTR, that is posteromedial soft tissue resection. Posteromedial soft tissue reaction. Now we will move on to 3 to 5 years. That is, we have here, see, between 3 and 5 the letter 4 comes, and we know that there are 4 chambers in the heart. So it would be Dillwyn Evans procedure. Dillwyn, now that is you are winning the 4 chamber. Evan, that is it would be the even number. That is 4 procedure. Now we move on to 5 to 8 years, and it is Dyer's osteotomy. Now in Dyer's osteotomy, you should remember that it is dying. See, in PM, it was the Prime Minister that was born, and he was having 4 heart chambers, and then he is dying. So that is Dyer's osteotomy. Now, you know, after dying, we will need a Wedge. Why wedge? Because to transport and to take him on shoulder to where the dead bodies are burnt. So in 8 to 10 years, we will have require wedge. What would be that? Wedge tarsectomy. And then again for 10 greater than 10 years, we should remember that we will do because the joint has become quite permanent, and therefore we will do triple arthrodesis. Triple arthrodesis or external fixator can be used. Just for the sake of understanding, you can see that in Evans, what we were doing in Dilwil Evans procedure. In Dilwil Evans procedure, suppose this is the leg, so this part of the leg was cut, this was resected, and the rest part was joined. And this was done at the calcaneocuboid joint. That is, again, CC, cardiac will have CCA. Now, when we move on to the Dyer's osteostomy, in this, again, there is wedge dissection, and then at the age to 10 years, we have wedge tarsectomy. Again, in Dyer's, we are dying. Just remember the name because it would be really difficult to recall it in the exam. But again, if somebody is really interested, one can always go through it. Finally, see, in greater than 10 years, what we are doing in triple arthrodesis, we are rearranging it. Where is navicular, tarsal, and then we have cuboid and calcaneum. These are all joined. Now we call it fusion of NTCC, that is TN, CC and TC. Now this was the regarding the treatment, but before going to the treatment, we have completed the treatment because it is the most important part. But right now we are going to have a look over the pathophysiology of the disease. What is happening? See, something are erratic, not arranged in order. You can always, because I'm not teaching it for the first timer who is studying. I am teaching this for those students who are have good basic understanding, but somehow jumble up the information here or there. I'm trying to provide a cue to those students. So if you are first time student, and then it is a big no-no to watch this channel right now. You go and cover your basics, and then come here if needed. Now, what happens in CTEV? Now, CTEV we have cave abnormalities. Now, cave is cavus, adduction, varus, equinus. These are all the abnormalities that are happening. So how we will remember? See. Here we are moving from distal to more proximal part. Now, varus. Now you should remember that how is this formed? Cavus is formed due to. Let us first write it down. What are the cavus, adduction, joint, Now, what are the pathologies that is seen in CTEV? Now, in CTEV, we used to remember that we can remember this by mnemonic cave. Now, in cave, you have to remember that this is cavus. A is for adduction. Now, cavus occurs at the arch level. This will be as we move from distal to proximal part of the foot, and same way here, all the pathologies will move. This would be similar. Now, adduction would occur at the subtalar joint. Now, something that is occurring at the subtalar. If talus is here, then it is occurring at the subtalar joint. So, what are the joints that would be involved in it? Adduction. That would be, see here talus, here is navicular. So, talonavicular joint, and here will be calcaneocuboid. So, in short, you can remember it by the mnemonic TNCC. Now, in TNCC, you can remember this talonavicular and calcaneocuboid. In varus, what is happening is there is the inversion of foot. That would be occurring at the level of the talocalcaneal joint. You can also remember that talocalcaneal, talus is here, talus is at the top, and calcaneal is here. So now the movement is, whatever movement we are talking about, it is from here that we are talking about for the varus. So that would be talocalcaneal. Now in equinus, it would be nothing but a high arched hyperplantar flexion. Now we move ahead. Now here we have to remember that there are a number of fractures and ailments occurring in the players, and then we will go it in sport wise. Now firstly we can go through the goalkeeper's thumb. Now what happens in goalkeeper's thumb is that it can also be remembered as skier's thumb. See, when you count the number of players from the goal side, so goalkeeper is the first player. So remember that since he's the first player, this will be occurring in the first finger, that is the thumb. What happens in there? Remember that in first finger there is ulnar collateral ligament that get avulged, and it can trap adductor pollicis, which is also known as Steiner's lesion. See, the lateral side is mostly supplied by what? That is, first thumb is supplied by the thenar muscles are supplied by the median nerve, but rest of the supply that is occurring in the hand is largely by the ulnar nerve. So you can remember that first in the first position is given to the hand's ulnar. So therefore, ulnar collateral ligament. That way also you can remember. So what happens is that adductor pollicis gets trapped, and that is known as Steiner's lesion. What I do is that I immediately transfer these to my choti copy. Now we move on to the next, that is baseball. Now in baseball, what you have to remember is in baseball or mallet. If you have seen a mallet, mallet is something like this. If you have played cricket, then mallet is that is similar to hammer, but since that is similar to hammer kind of thing. But in cricket, when you want to increase the stroke of the bat, you often use mallet. And if many of you would have seen that. So baseball or mallet, this is towards the back side. This is extensor compartment muscles are ruptured. Which muscle specifically can get ruptured here? So extensor tendon muscles will get ruptured. So what will happen? There will be inability to extend. There will be inability to extend. So it will continuously remain. Finger will remain in flexion position. Now rugby jersey finger. Now in rugby or jersey, what happens is flexor tendon is ruptured, and it always remains in persistently extended position. Remember, is flexor tendon ruptured? By that, it remains in persistently extended position. Again, if you find this information difficult to ratify, then you can understand that there was a movie that was released as Jersey, in which Nani or Shahid Kapoor both they die. And what happens in die after long duration after many hours of death is that body lies in complete extension. So from that you can recall, okay, fine, in rugby or jersey we have extension like kind of thing. So remember from here. Now we move on to the swan neck. What is swan neck deformity? Now in swan neck is that there is entrapment. In swan neck we have SFD. What is street food of Delhi. Now swan, that is flexion occurring at distal interphalangeal joint, whereas extension happening at proximal interphalangeal joint. So what we have to remember is that street food of Delhi here will show swan neck, flexion, distal interphalangeal joint. Swan neck, flexion, distal interphalangeal joint. That is comes to relate to street food of Delhi. And once you remember this, you can always recall that extension would be occurring at the proximal interphalangeal joint. Trust me, this becomes very confusing in the exam, and you end up marking wrong answer. What is boutonniere's deformity? In boutonnieres, you can see that it is near to the finger. So that is extension at distal interphalangeal joint and flexion at proximal interphalangeal joint. So how you can remember is you break down the boutonnieres, bow-like structure forming at near joint. That is flexion at bow means what? Bow means bottom or dhanush, you know. In dhanush, what happens is there is a bend like this, and that is occurring in the proximal interphalangeal joint. That is near to the body. Also, we can remember that distal interphalangeal joint nodule is known as Haberden nodule, and proximal interphalangeal joint is known as Bouchard. You can remember this by, now we remember our first year, that is usually we used to go to the dissection hall and we used to do in physiology we used to do BP measurement. So by that you can remember that dissection hall and BP measurement. And distal interphalangeal joint, Haberden nodules, proximal Bouchard nodules, proximal interphalangeal joint. You can remember this in this way. You can also, this is a DH and BP way, but you can also avoid this way. There is another kind of way that you can remember is, that is in Dean coming distal interphalangeal joint and bow. Again, we have seen the boutonnieres. Now boutonnieres, from that boutonnieres, you can also remember Bouchard. So what can you remember that? From that you can take out that it is occurring at the proximal interphalangeal joint. Now we move on to the entrapment or the contracture, in which there is a trigger finger that gets contracture at the A1 pulley level of flexor tendon, and thus the finger always remains in persistent flexion position. Now we move on to the Harris classification. Now, what is Harris classification system? You have to remember it by the mnemonic Salter. What we can remember in Salter first is subcapital epiphysis. A is that is occurring above the growth plate. Then it is occurring lower and total. Now here is a cross mnemonic that you have to remember, that lower L is not associated with L, that is lateral condyle of humerus. And in total it does not go with T, that is Tilloch's fracture. Now also you should remember that in A we have Thurston-Holland sign. Thurston-Holland sign. Just remember that in above the growth plate occurring there is Thurston-Holland sign. And ultimately there is a crush injury. Now we move on to the Trendelenburg. How you can remember Trendelenburg? You can remember it by the mnemonic Dolly. That is in here what we can show is Trendelenburg gait. So dropping on the opposite side and lurching on the ipsilateral side. That is dropping in the opposite side and lurching on the ipsilateral side, because they once AIMS asked question and it was really confusing. So remember all this. Now when bilateral hips are involved, then it is known as waddling gait. Now we move on to the class of different bone tumors. Now bone tumors, you have to remember that most common bone tumor, benign bone tumor is osteochondroma. But before we move in there, let's see what are the lesions that are occurring in the epiphysis. Lesion occurring in epiphysis is ECG, that is Ewing sarcoma. No. In epiphysis ECG, Ewing's is occurring in diaphysis. So what would be the other lesion that would be happening here? Now for epiphysis, we have to remember that there is two tumors that are found. That is for C, you can remember it is as chondroblastoma, and for the G you can remember as giant cell tumor. Now remember that for now what we have to move on to now, we have to remember that chondroblastoma. Now in chondroblastoma, in everything here he's having CCC, that is chondroblastoma occurring in child. And remember, this is also known as Codman's tumor. See, Codman's angle is found in osteosarcoma, but here it is Codman's tumor. This is known as Codman's tumor. Now chicken wire appearance, and that's it. All you have to remember is that all the diseases that are written here, all starts with C, and we have ultimately here epiphyseal involvement. Now what happens is in 30 to 40 years there will be distal end of the radius involved, and there will be soap bubble formation that results in osteoblastoma. Now remember, what are the, just as we are going to read osteoblastoma, I would like to tell you the background of using which radiography you will use in for which purpose. Remember that, osteoid, something that refers to calcium deposition or bone formation. So when you have 2O, then the thing gets changed, that is osteoid osteoma. So in osteoid osteoma, what you have to remember that, this is very basic line you should remember, that all in bone related cases, you do MRI, but for osteoid osteoma, CT scan is the investigation of choice. Now we move on to the diaphyseal part. Now in diaphyseal, you should remember that we can have that is osteoblastoma. So what would be the presenting feature of osteoblastoma? You should remember that here lots of OO are coming. That means that person is crying in pain or saying oh. And when you are in pain, you tend to speak out like these kind of sounds. So that means that pain is integral to osteoblastoma. So when this pain would be occurring, this would be occurring at the night time, which can be relieved by NSAIDs. And what is the treatment? Treatment is CT guided radiofrequency ablation. Now we move on to the Ewing sarcoma. Now Ewing sarcoma, you should remember that Ewing, whenever a cricket team is often called Indian wing or Australian wing, so any wing kind of thing. So you should remember that here the translocation is 1122. That is 11 members in one team, 11 members in other teams, so that comes out to be 22. And another major important thing, that since Ewing have 5 letters, remember one of information I missed earlier for osteoblastoma is that in diaphysis, NSAID would be the drug that will be used for the relief of pain. Now we move on to the Ewing sarcoma again. In Ewing sarcoma, Ewing consists of a cricket team. A cricket team has 11 players, and now we have 2 words, so 11.22. So that is the translocation that is happening. Also remember there will be onion periosteal reaction, and Homer right pseudorosette is seen, which is a pseudorosette, and it is the most radiosensitive tumor. Now we move on to next to the osteosarcoma. In that we get in osteosarcoma we get this, we get in metaphysis, and this is lifting of the periosteum. Periosteum is lifted, and this is radio resistant, and it is often radiotherapy induced. Now We move on to the other things happening in the diaphysis, that is single unicameral bone cyst. Now in single unicameral bone cyst, there will be falling leaf sign or trapdoor appearance. But in aneurysmal bone cyst, you will have soap bubble appearance. See, remember, aneurysmal cyst will have soap bubble kind of thing appearance, and it is not reaching the epiphysis. Now, soap bubble, it is not reaching the epiphysis. And you know, aneurysm will form in most of the time. In which region? It will be formed in the metaphysis. Why? Because name is the aneurysm. And where is the maximum number of arteries seen in a bone? It is seen in the metaphysis. So aneurysmal bone cyst will start from the metaphysis. Now we move on to the enchondroma. Now enchondroma, what happens in enchondroma? There is multiple frequency disease there. It involves generally involves short bone. Short bones are involved in enchondroma. Now it can manifest in two forms. One is Olier's disease. Olier's disease is only enchondro. Now here, short bony lesion is associated with hemangioma, and when it is associated with hemangioma, it gives out Maffucci syndrome. Now we move on to the fibrous dysplasia. Now fibrous dysplasia, it is occurring, tumor invasion is in the neck of femur. This is a pathological fracture. And ground glass appearance, Shepherd Cook deformity, Chinese letter appearance and all, and McCuney Albright, precoccus puberty plus scapulated spot. Now just here, I would like to cover in brief the treatment portion. Now remember that in treatment you can remember that osteosarcoma and chondrosarcoma. Since sarcoma is name is coming, so here an aggressive tumor is spreading, so we will do surgery would be the treatment of choice. Remember, OC, osteosarcoma and chondrosarcoma. In both, what will be happening? Surgery. Now we move on to events. We remember that chemotherapy, radiotherapy. Now in simple bone cyst, what will we do? We'll do simple curettage, whereas in osteoblastoma, CT guided radiofrequency ablation. Again, we write it down, and then we move on to the single best treatment that is given in all cases. Now we move on to the different triads that we see. Femster triad. Now femster triad means something that is seen in females, something that is seen more predominantly in male. And that is near the errant joint, because we are talking both about male and females, and it has to be, there should be some jointer. Now you can remember that there is periarticular osteopenia. That is periarticular osteopenia. Erosions, reduced joint space. Erosions, reduced joint space. Now Odonoc trod. Now Odonoc trod is happening largely in football. What happens in Odonoc trod? In Odonoc trod is, remember that this is, for suppose this is the leg. So this is the right leg. Now what happens is that from laterally somebody kicks, when somebody kicks here, so the joint that are joining here would get disrupted, and this results in MCL, ACL and meniscus, medial meniscus. Now we move on to the terrible triad of elbow. Now what happens is, in terrible triad of elbow, you should remember that there is elbow dislocation, radial head fracture and coronal fracture. So why is it happening? So see, in this also three tip constant thing remains. So now what we should remember, that humerus. Now humerus is kept in attachment with forearm. So how is it attached? See, suppose this is humerus. Now this is your radius. So what is happening is that there is fracture of the radial head. Now what happens is there is fracture coronoid. Fracture coronoid ho gaya. And then again next we will have displacement of fracture of the ulna. Now we move on to the spine X-rays approach. So there is not much in this. Everything you should be. There's no such trick here. How to remember? But I will discuss with you the important ones in which people often get trapped. See, Paget's disease often is confusing because it shows feature of both osteoblastic and osteolytic. Now what happens in the blastic phase? In blastic phase, it will be showing ivory vertebra. But on osteolytic and in this, other phases where it shows mixture of osteoblastic and osteolytic, it will have picture frame appearance. What is picture frame appearance here? See, the periphery, it is osteoblastic, but the center, it is osteolytic, therefore blackish. Here, blastic, therefore whitish. Now we move on to skull x-rays. Now in skull x-rays you have to remember that you will always salt and pepper. Now we will go through skull x-rays pattern approach. Now what we will do is that in PTH we will have salt and pepper appearance. Now we move on to geographical lesions. How to remember geographical lesions? See, geographical lesions are somewhat like this, and you will be seeing that the cells are also somewhat like this. So any cells are also at a prokaryote level there or eukaryote level, they are like this also. So geographical would look similar. So any pathology with naming with having cell name in it. For example, if something is derived from eosinophil or something is derived from Langerhans cell. So eosinophilic granulomatosis, Langerhans cells, histiocytosis, they will all have geographical lesions. But there is one additional information regarding Sturge-Weber syndrome. Now what happens in Sturge-Weber syndrome? There is port wine stain. Now when there is port wine stain, see, there is port wine stain here occurring. So something in the eye of there, what is that? Is kala motia. Everything is here related to color. Kala, port wine stain. Kala motia is also known as glaucoma. And then we will have, see, tram track appearance, tram track calcification on the head. And refractory seizures. Because so much of track would be leaving here, so we will having refractory seizures. So this is all the feature of Sturge-Weber syndrome. Now one thing that is very important here is Sturge-Weber syndrome is not inherited but sporadic. It is not inherited. Normally what happens is that we congenital diseases, we tend to think that it is inherited but not here. It is not inherited but sporadic. Now we come on to the chronic osteomyelitis. This is a really important thing. Now in chronic osteomyelitis, you should remember that involucrum would be lucent. How you can remember that? In this, involucrum will be lucent. And sequestrum, not remember sequestrum would be hardened. So therefore, there would be sclerotic happening, that is S.SST. Now, chronic osteomyelitis, what we will have? It will have center sclerotic, and that would be surrounded by granulation tissue, that is involucrum. And there would, this is known as paprika sign, and there would be cloaca also, which would be discharging sinus. So all these are discussed here. Now we move on to now we directly move on to the braces. Now in braces, you also all know what braces is used for what, and but one thing that is standing out here is Charleston brace. See, Charleston brace is what? Charleston brace is for a King Charles. So what will be King Charles? King Charles would try to show to the world that he is a strong person. So he would not wear this brace during daytime, but only during night time. Now we move on to the different angle that is often asked. Firstly, kite's angles is associated with what? Kite's angle is associated with CTEV. Kite's angle is CTEV. So you remember that you use your, see, if you're not able to remember kite and CTEV, you can remember in this way that you fly the kite in Cetina or something like that. Now we move on to the calcanean fracture. Now calcanean fracture, what happens is that BCG, that is Bohler, and next is Gisane. This is associated with calcaneal fracture. Now, developmental dysplasia of hip, ultrasonography. What will happen is there is alpha angle, there is beta angle. So there would be increasing or decreasing. So how will you remember? See, in calcaneal fracture, Bohler is, it can also be said as lower, it rhymes. Gisane means gain. So in Gisane increases and Bohler decreases in calcaneal fracture. Now what happens in developmental dysplasia of hip ultrasonography? Here, vowels do not stick together. That is alpha angle decreases and beta angle increases. Now we move on to the next fracture, that is Kohler fracture. So here you can remember that Kohli lives in Navi Mumbai. See, he lives in the Mumbai's most richest part, but just for the sake of our learning, Kohli is from Navi Mumbai. So Kohler is navicular fracture. Now Kinbock fracture. What happens in Kinbock fracture? Now in Kinbock fracture, there is lunate avascular necrosis. How you will remember this Kinbock as lunate avascular necrosis? That is, if you remember that Luna in 90s or early 2000s were very cheap bikes, but very highly usable. And there used to be in a house a single Luna, so all the kin used to box with each other so that they can use Luna for their comfort. So by that you can remember that kin box is associated with lunate avascular necrosis. Now we move on to the sclerosed calcaneal epiphysis. Now Sever's disease is associated. See, this is calcaneum is the part that gets a lot of waste material or dust particles and all. So what you will want? You will want it to throw this waste in a sewer. So this waste is thrown in a sewer, and therefore it is known as Sever's disease. Now we move on to the tibial epiphysis. Now in tibial epiphysis is sclerosed, and we can remember it by it is Osgood-Schlatter disease, and Osgood can be remembered by OT. And it is occurring at tibial epiphysis. Now we move on to the next segment, that is fractures. Now again, in fractures you have to remember that what is the score that is used for estimating the chances of a fracture in an osteoporotic bone. So this is done by Merrill's criteria. Merrill's criteria. This is done by Merrill's criteria. In Merrill's criteria, what you remember that there is pathological fracture happening. So what can it can be often learned with the component lisp. Now lisps. Now LI for lesion, S for site, P for pain, and again S for size. These are the criteria that determine the chances of osteoporotic fracture. So in this, the score is given between 1, 2, 3. So see, first we will fill up the lesion one. So remember that when a lesion is blastic, then it will have minimum chances of fracture, and when it is osteolytic, then it will have maximum chances of fracture. So this is the one condition. Now site is important because see, it boils down to the weight of carrying nature of the body. Now in first upper limb has only weight of the upper limb. So you know, famous dialogue, 2.5 kilo. So it does not have to support the whole body. So therefore, if there is some pain occurring in the upper limb, so we will keep it as okay, fine. If it is an upper limb, not much weight is has to carry, so fracture will not happen, or there are least chances. So therefore, upper limb would have least chances. But second is here point that lower limb is having second because it is carrying the weight of the upper body also, and the that is the whole weight of the body and supporting the body. It's by itself only. Then what we will have ahead? Now we will be having jointer. Now jointer is hip here. Jointer is hip. Now hip is a jointer here, so it will carry the whole body part weight. So if something pain is happening near the hip, so there is very high chances that fracture can occur. Now we move on to the pain. That definitely mild pain will have lesser chances, whereas severe pain will have higher chances. Size. Now size is, remember that, less than 1/3, 1/3 to 2/3, that is greater than 2/3. Now we move on to the Gustello-Anderson classification. Now what does happen in Gustello-Anderson classification? In first, you will have less than 1 centimeter lesion. In second, you will have 1 centimeter to 10 centimeter lesion. In third, you will have greater than 10 centimeter lesion. In fourth, how you can remember the fourth one? Fourth one can be remembered by, that was a trick question. There is no fourth. There is a greater than 3. Now it's now 3 is further divided into A, B, C. Now A is extensive soft tissue damage happening here. Extensive soft tissue damage happening here. In B, what is happening is that periosteum is getting stripped off from the bone. So what is happening is periosteal stripping. Whereas in C, you will have circulatory disturbances. Now we move on to the Jones fracture. Now what is Jones fracture? In Jones fracture, you have to remember that it is occurring at the neck, when pseudo-Jones is occurring at the tip. Pseudo-Jones is having poorer prognosis. Jones is having poorer prognosis. Pseudo-Jones have good prognosis, and things like that have been taught in the earlier part of the video. Now we move on to the osteochondritis. Now what happens in osteochondritis? That there can be two kinds of things: Eileen and Freiberg. Now in Eileen, 5th metatarsal, and in Freiberg, 2nd metatarsal. How you can remember? See, Freiberg is February is 2nd month. Eileen is an island. Island is always at the that is surrounded by water on all sides. Okay, so here, if we have to draw the finger, then there would be 5th metatarsal. That is the last metatarsal. It would be bordering the water. Why? Because see, if some island is this and some giant makes his foot here, so this will be the 5th metatarsal that would be getting involved or in touch with water. By that, you can remember that Eileen is 5th metatarsal. Now we move on to the avascular necrosis. Just remember, in avascular necrosis is that 2B is associated with crescent. Now you can remember that Fickett and Arlett. This is apart from the Fickett and Arlett classification. Now callus earliest. Now callus formation is earliest at 3 weeks. Delayed union 5 months. or 6 months. Non-union up to a year or 9 months. So remember, callus is 3 weeks. Now delayed union. Now delayed union would be at 6 weeks. Right. Instead of the entire thing and redo. Now we move on to the callus formation. Callus earliest forms at 3rd week. Delayed union occurring at 6 month. Non-union occurring at 9 month. Now in Colles fracture, they often ask that what is the order of joining of the bone. You have to remember the order. So what is the order in Colles fracture that we use? First is pronation, then palmar flexion, then ulnar deviation. This all can be remembered by the word propano. Now we move on to the fractures of head to toe. Now we move on to the supracondylar fracture of humerus. Something that is important in it are Bowman angle, Dunlop traction, 3-point maintained, closed reduction plus K wire. So what you can do here? See, supracondylar human fracture is associated with a lot of fighting things like gun stock classification, gun stock deformity is seen. Now bow, that is again used for killing people. Traction, Dunlop. See, this is all occurring in humerus bone. This is occurring in humerus bone, and there is all the people are sitting in a dull way. Now we move on to the distal end of the radius fracture. Rest whatever I have skipped, those portions you will have to understand and rectify. For that, I personally also have not made mnemonics regarding those topics, so you will have to find your own way for remembering those topics. Now we are going to do study of distal end of radius fracture. So we have already done Colles and Smith, and now we come on to the Barton's fracture. Now in Barton's fracture, you should remember that inside a bar there was a lot of drinking, so that is intra-articular. See, this can be better phrased in this way, that if you have to drink a ton of alcohol, then you have to go inside the bar. Now Schoffer or Hutchinson. Remember that earlier there was an advertisement that was always associated with, in that Hutch mobile was shown, and in that there was a small dog that which reach everywhere, and the mobile network then claimed that wherever you go, the network will follow. So based on that line, we need driver also. Wherever I go, then my driver should follow. So therefore, Schoffer fracture and Hutchinson fracture both are one and the same thing. So what is happening here in Schoffer fracture or Hutchinson fracture? That is distal end of the radius, the distal process gets fractured, and this leads to avulsion of brachioradialis. Now we come on to the one also in many of the times they will ask the arrangement of the carpal bone. So always learn the carpal bone in this order: cellar or collar, as we say in English. I prefer cellar. So here what would be? It would be capitate at the distal most part, then lunate, and then we have radial stellate process, radius bone. So these are all in alignment. Once again, Colles fracture, you have to remember that it is propaganda U. This is the order of correction in Colles fracture. That is pronation, palmar flexion, and then ulnar. Now we move on to the important spine fractures. Now spine fracture, you have to remember some of the spine fractures that are spine fractures. Just remember that C1 is associated with Jefferson. See, Jefferson was something first in the US political system, Thomas Jefferson. So you can call him one of the first founding father of USA. So since he was, I think I'm not very much confirmed, he was first there. So C1 is associated with Jefferson. Now C2, C3 is associated with hangman fracture, and C7 is associated with Clay-Chauvelier's fracture. Now we come on to the lower limb fracture. Now how to remember lower limb fracture? We know the lower limb fracture, we have discussed earlier what is bumper fracture. Now Hoppa's fracture. Now Hoppa's fracture one will have difficulty in learning. So just remember a single line. Everybody hopping because of corona. Okay? Now what is this? That in coronal plane there will be fracture of femoral condyle. Coronal cornea a parallel. So now what you can do is that in coronal plane there is everybody hopping because of corona. See, corona has killed a lot of people, and it made the whole economy, paralyzed the whole of the economy. So everybody is kind of hopping so that they can fight this situation. This is you can remember in a philosophical way, but remember here that coronal plane of femoral condyle that is associated with Hoppa's fracture. Now we come on to the Chopard's ligament. Now Chopard is intertarsal, and Lis franc. Lis franc, you can remember, is TMT Saria. It is very strong. Now English and French people are very strong. They are joined by a undersea tunnel that is made of TMT Saria, that is tarsometatarsal. Now we come on towards the orthoplasty. Now we have to remember that in Thompson there is no fenestration, but in Austin Moore there is two fenestrations. Now moving ahead, see in Steinman pin, it is smooth, solid, and this is for the cortical bone. Whereas Denham pin for cancellous. See, if you are going to be kept inside a den or harmed, then what you will try to cancel those things, now. So therefore, Denham pin is for cancellous bone. Now Herbert screw is for scaphoid. Now remember Herbert screw. Now Herbert screw is for the scaphoid. So remember that here, and most common bone fractured for the in the carpal bones is scaphoid. So remember that. If you just remember this one thing, that Herbert screw is for the carpal bones, and most common carpal bones fractured is scaphoid. So remember, okay, fine. Herbert screw is being used for scaphoid bone fracture. Now, don't we see the splints and tractions that we used? Splints and traction. In this, you remember that there is in Perkins there are perks being given. So when perks are given, then you have to cross some bottleneck or path. So therefore, wedge would be used in this. And in Russell is for right angle. Leg would be in the sheets. These are the sheets, and this thread would be vertical. Dunlop traction is for the humerus. Yeah. Now shoulder dislocation. Shoulder dislocation. This was asked in INSCT November 2023. Now in this shoulder dislocation, what we should understand is that antero-inferior glenoid labrum avulsion is called Bankart, and the elevated part that is there in the humerus bone, that is known as Hill-Sachs. So how you will remember these two things? Because these both are very lots of time confusing. So see, glenoid labrum. Now glenoid labrum antero-inferior part. This is something. Now this is known as Bankart lesion. Now remember that bank takes all the money from the people, so it will be having a dip, so that he can extract money from others. So that is Bankart. Whereas Hill-Sachs is posterior superior. Now number of tests is done, that is Hamilton test, Dugas test, Collaway's test. Now you can remember that Hamilton-Miller test. Hamilton-Miller, that is millimeter something. You can Miller is something that is your millimeter, and that is in which scale is used. So Miller is equal to millimeter. Now 1 millimeter this is used in the form of scale. Now Dugas. Now Dugas test, you can remember it as Dukhega. And Collaway test is circumference. There is increased in girth. The shoulder, when it is dislocated, there will be ultimate increase in its girth. Now we come on to the last part, that is pulled elbow. Now pulled elbow, when you use pull is equal to, here P is coming pronation, plus you know the child is being rotated by extending his hand. So what you will, there is no doubt there will be pull, there would be a pull, that is pronation, and then it would be done in the extension. So what will be the treatment? Treatment will be the exact opposite. What you will do? You will do flexion plus supination. Now there is modified Insal-Salvati index that is used for patella. Now we come on to the last part, that is classification. Now last part is remaining classification system that I will cover in later part. Now we are in the last leg of the revision. Now we will see some important things like for posterior approach for acetabulum fracture. Once the name is Cocker Langenbach approach. Langenbach coming from the Lange Baxe. So that is for the acetabulum fracture. Now Hawkins sign. See, Hawkins sign, Hawkins classification. This was asked in INICT November 23. And you should remember that Hawkins. See, if someone does urination, then if someone does urination in a swimming pool, very often there is a complaint that people are urinating in the swimming pool, and if there is no way to find out who did what. So if accidentally one guy is caught doing urination, so everybody in the pool will want to know who has done that. So everybody would say, "Oh, that would be a cause of shame. Oh, tell us." Okay, everybody will ask to tell them. So it will be tell us. And also, since I have used swimming pool here, remember that this Hawkinson urea swimming pool sign is seen. Okay, in Hawkinson urea. Now we come on to the classification system. See, it is one of the most confusing part, and we would like to complete now for Zoodet. Now Zoodet is jod. So where upper body and lower body meet. If you have learned the Merrill's criteria, highest value was given to hip joint. So Zoodet is associated with acetabulum. Now Young and Burgess. See, often in for birth of baby, a young girl is above the legal age, that is above 21 years and 24 years, but below 30 years is desired for carrying a baby. So therefore, Young and Burgess is related to pelvic fracture. Now Sharchkar is associated with tibia fracture. Now if you recall the Kapil Sharma show, in that there is a bumper that is Kikusharda is bumper. Now that bumper is capable of eating each and everything. So any word that has chart in it, it will be rapidly eaten by this bumper. So Sachartkar is tibia fracture. And also remember that bumper fracture is associated with tibia. Why? Because in forensic we would have studied, and earlier I've also taught that in tibia fracture it is caused by when bumper strikes. Now knee is humerus. It is often known to everybody. Now Gartland is subcondylar humerus. Now Gartland supracondylar humerus fracture. So what will happen here? See, all these things like gun stock, Bowman angle, Dunlop traction, this is all associated with supracondylar humerus fracture. Milch. Now Milch is associated with lateral condyle of humerus. Now Milch have L, so L. And also if you remember that while milking the cow, if somebody has seen how the cow is milked, the cow's breasts are in the midline position, and then it is pulled laterally by the milkman into his bucket. So whenever there is something associated with milch, so it would be lateral condyle of humerus fracture. Now we come on to the Bado fracture. Bado, if you convert it in Hindi, Bada, that is to become big. What is big? Something can be big as mountain. So Montegia fracture. Now neck of femur fracture. See, neck is the most important part and is one of the most studied segments. And since this segment is studied more, so everybody will come with their own classification. So remember that in neck of femur we have Pipkin, Garden, and Powell classification. See, if you want to remember, here also I can give you that the name of the vegetables are here being given in neck of femur fracture. Neck of femur is pumpkin. Pipkin can be written as pumpkin, that is in Garden, and you are carrying those with towel or Powell. Now we come on to this. So always remember that anything that is having complexity, see, neck of femur fracture came in non-union. So people will try to classify and predict differently. So because it is one of the larger problems, so we will have multiple classification for that. Now we come on to the Evan classification. Now Evan classification is what is Evan? Where Evan will be related? It will be related in IT infrastructure, IT fracture. So IT fracture, IT, that is Bangalore. You can visualize. So IT is intertrochanteric fracture. Or you can also remember, but it can be a little bit confusing, that Pimkin, Garden, Powell, all these products are being taken in a van. So when it is neck of femur, the other one would be intertrochanteric. Now Dennis Weber. Now Dennis Weber is associated with ankle fracture. See, remember, the name is itself saying Weber, and Danish, down web is our foot, and foot we have in the joint ankle fracture. Now we come on to the Kuwada, having Thompson test. Now Kuwada can be written as Kuwada. Now Kuwada, it is having Kuwada. बेकार वाला था ना, बेकार वाले में क्या होता है कि आप अजीब अजीब कसम खाते हैं, तो इसमें क्या हुआ, आप मिर्चा खाने की कसम खा गए, तो what will happen? चिल्ली, वो भी दो चिल्ली खाएंगे, तो Achilles tendon tear, and test is for Achilles tendon tear is Thompson test. You can remember this as thumping the chest. So here we have chili, and you are thumping those everywhere where the temperature is rising, and therefore it is Kuwada. Now often anterior and posterior dislocation of the hip is asked. So how to remember? You can remember this by, see, in anterior what we are having? We are having Faber, and posterior we are having Fadir. So something is going distance, so it will appear small, so therefore the limb is shortened here. Reverse, limb is lengthened. Okay, now what you will do is, now in posterior obviously sciatic nerve will be gone, in anterior femoral nerve. See, anything that is going away from you will be going far.